a tie between Dr. Monsef Farnoush and Dr. Ahmed Shafi. First and second prize, and the third prize for Dr. Muhammad Amraza.
Good afternoon, Alexandria. Give me a big cheer. So friends, we are going to play the Retina Premier League here in Alexandria. And for that, first of all, I'd like to call on Dr. Ihab. He is the match referee. And Dr. Ihab, you just
introduce the judges. So this is the Premier League, so I'd like to and as the referee will give an independent vote for the better quality of presentation. So guys, you have to
kindly have the introduction. introduction of the witness witness, please. Joining on Zoom. The king of the visionary superstars. Now I call upon the captains of both the teams. Captain, so Dr. Noor from Witness Wonders and Dr. Magen from, and then we are going to have a toss now.
So the red team will go for tails, the blue team will go for heads, and let's begin the game. Tail starts.
So Dr. Noor, you have to choose whether you are going to come first or you want them to come first for presentation. You want them to come first.
Maggie, you're starting.
Dr. Magen, you have to decide who is going to come first.
She choose who starts.
You have to start. Dr. Wazia is going to present first. Kindly please play the video. So before that, before we start, I'll just explain a brief rule theme by raising which video they like. So each judge is 1 mark. And then I'll ask the audience, and the audience will give a voice vote to which video they like, and the audience is also 1 mark. And there is a star player in both the teams. So I think for the blue team, the star player is Dr. Ahmed Salem, and for the red team, Dr. Tawfiq. So both the players, if when they come, they will have. So now, for the first round, Dr. Wazia from the blue team, she's going to start the proceedings. Can I have Dr. Wazia's video, please?
Is it on? Hello. I hope I live up to Wonder Woman. Okay. Since I'm not a vitreoretinal surgeon, I'm a medical retinal and oncology specialist, I'm going to just present a case that's kind of stumped me a little bit. A 45-year-old previously held female our ophthalmology department at UVMC and with a referral diagnosis of a suspicious choroidal lesion in the right eye. She had negative medical history, family history. She's a regular hookah smoker. On examination, her best corrected visual acuity was 20/25 in the right eye and 20/20 in the left. The exam was completely normal. On dilated complete exam, there was a quiet acellular vitreous in both eyes, but in the right eye, right at the macula, there was an elevated choroidal lesion with a 2 by 3 millimeter basal diameter with overlying subretinal fluid, and there was no pertinent findings in the left eye. On autofluorescence, there are hyper and hypoautofluorescence stippling at the lesion, and And on B scan, there's a dome-shaped, regularly structured, hyperechoic lesion of the choroid with a thickness of around 2.18 millimeters and no distinct extrascleral extension. On fluorid scene, we had plain diffuse staining of the entire lesion, and on ICG, we had early hypocyanescence of the lesion that persisted late into angiography. This was the OCT. You can see the choroidal elevation clearly and some shroom and subretinal fluid. So the differential diagnosis of an amelanotic choroidal mass includes systemic metastasis, amelanotic choroidal nevi or melanoma, uveal lymphoma, or masqueraders such as sarcoidosis or TB. We did a complete oncological screening. Mammo was negative, brain and orbit MRI were negative. A CT just relevant for a few scattered subseptometric lymph nodes in the perivascular and bilateral hilar spaces. So the decision was made for close follow-up, considering the difficulty, low yield potential, and visual threatening risk of a biopsy of the lesion. At 3-month follow-up, there was an increase in the size of the lesion and increase in the subretinal fluid. A PET scan at that point was ordered, and it showed avid thoracic, abdominal, and pelvic lymphadenopathy. However, 1 day after the scan, we were still in COVID. The patient developed fever and upper respiratory tract symptoms and tested positive for COVID. So the biopsy of the lymph nodes was deferred because oncology suspected the viral illness may have caused the lymphadenopathy and that it was completely unrelated to the choroidal lesion. So at the 6 months from initial presentation, 3 months after that first PET scan, the vision had worsened to 2200 at this point. Choroidal lesion had increased in size. The largest basal diameter was 6.8 and the thickness was 3. Their repeat PET scan showed persistent lymphadenopathy. So at that point, an endobronchial ultrasound-guided biopsy was performed, and it showed a non-necrotizing granuloma suggestive of sarcoidosis. So the diagnosis in this case was a sarcoid granuloma, which is the only presenting side symptoms. So systemic steroid therapy was initiated, resulting in improvement in vision to 20/60 and complete regression of the lesion with residual chororetinal atrophy. This is before and after the steroid treatment. And there's 26 published cases of sarcoid granulomas in the literature. Only 5 patients had the sarcoidosis diagnosis prior to the identification of the choroidal granuloma. So, and in our case, as I mentioned, the choroidal granuloma was the only clinical manifestation of sarcoidosis and discovered only after systemic screening for neoplasms was performed. So in case of any inconsistency between the symptoms, endoscopy, imaging, or if there's any doubt, please always check for sarcoid and other masqueraders in these cases, challenging cases.
After this challenging case of sarcoid granuloma, Dr. Noor, what is your plan? You go first. So Dr. Noor will present the case.
We really enjoyed it. It's a really a nice way of sharing knowledge. Okay. So I go for the vitreous wonders. That's the case of my misdiagnosis also. So it's a 67-year-old female. Primary diagnosis, she has ovarian cancer, reoperated 2 times and having a chemotherapy again. Under follow-up for since 4 years, and she is also close to me. Hospitalized for upper respiratory infection 2 months ago in the hospital and been in the ICU unit for a while. Complaint of visual loss started when she's in the ICU unit. Complaint about at least 1 month. Eye exam is performed, but immune response is diagnosed at 2 times cannula injection reversed the situation. So that's a consideration, calling the vitreous wonder. So visual acuity, when I examined the patient, visual acuity was flat motion bilaterally without no pain, out no. The plan that should be needed action. The infection consultation should be done, and after the cultures of blood, any catheter has been made, IV application started immediately, and we checked them with sample collection and culture is planned. So here's the video that you can see. It's a hand motion vision. It's really a very worst of the cases that I operated for a fungal endophthalmitis, which was endogenous in an immunocompromised patient. As you can see, I started with vitreous sampling in the start without opening the infusion line, and immediately I tried to get 2-3 milliliters of, copious amount of vitreous and directed down to the direct examination. And here we start. You can see multiple enormous amount of infiltrations, choroidal infiltrations. Actually, this infection starts from the choroid to retina, and when it is long time is seeds go to the vitreous, and then the vitrectomy is needed in this stage. Actually, as you can see, the posterior hyaloid there was very densely adhered into the optic disc everywhere. It was like a bad diabetic membrane where inflammation is very high. So I could not traction any of the posterior hyaloid. I just tried for the optic disc, but instead we have to delaminate and segment and delaminate, segment and delaminate all these epicenters, because underneath was the retina. So if we use any traction, we could cause a retinal tear hole, and we did not realize it, and ending with unsuccessful result. So at the end, I try to also indent, clean as much as I can. I think I feel satisfactory to remove as much as I can with the backflash, just making those infiltrations fluffy, and at the end, silicone oil. Now I have one slide, post-op slide. Are we good with the time, Sanjeev?
Last slide.
So this is the 2 or 1 month pictures. The patient did well, 0.05 vision under silicone oil, the eye remained fine. Thank you.
Thank you. Now to the colleagues. Dr. Ilham, you want to say something?
Yes, Noor. With the incoiling catheters and the patient can get candida or even aspergillosis, why haven't you thought about injecting first? Voriconazole. Especially that it was not that intense, not that dense of the inflammation.
Can you hear me? Yes. Okay. Now actually it was really bad because I took samples, a lot of amount of, so you can see the vitreous start of the surgery is a bit better. But with the cutter, I took most of the anterior mid-vitreous. So it was hand motion, both eyes, bilateral. The patient was really very anxious, unhappy. We started the IV treatment, and we planned I inject at the end of the cases, of course, and these eyes are really bad outcome eyes, so this treatment should be long, at least 4 months, 5 months, sometimes should be continued, which is the case for this patient. It was bilateral, it was hand motion, that's why I didn't have time, and the patient was really anxious to get rid of the situation, and there was a misdiagnosis, that kind of legal situations also about other factors.
Yeah, the eye was inflamed, and there was always the risk of carrying complications with the intervention as well. So now we have to weigh the risk-benefit issue as well.
But systemic is also effective treatment for this. When you start the systemic, it's also resolving a bit. You're right.
I think now we come to the hardest part for the judges. Both cases were spectacular, and I think they will be deciding which one wins this round. So, Dr. Ilham, the blue team, the red team, blue, Satish, red, the blue. So three to blue, and 2 red. Before that, I like the audience to vote. Yeah, the audience to watch is I'll ask for the red team. Who votes for the red team? Will you have to make a noise? And for the blue team? I think the red team won here from the audience. Three points to the red team and 3 points to the blue team. I think Dr. Shishir is keeping the score here. So now there's a tie, but according to the judges, I think the blue team had won, so the blue team has to come for the presentation. Okay, so Dr. Baha Abdullah is now going to present his video. Please play his video.